you can and should put bypass from the aorta. Сейчас, I'm sorry. I'm sorry, students. Сергей, здравствуйте. У меня лекция идет у иностранных студентов. Алло, Сергей Викторович. Сергей Викторович, у меня лекция идет у иностранных студентов, если вы меня слышите. Я вас не слышу. Sorry, it's head of department. Так, you can put here bypass from the aorta to the common femoral artery, да? It will be first steps, да? And secondary, the next steps, так, где у нас мышка? Next steps will be next bypass from the superficial femoral artery, да, to the popliteal. It will be next step. I'm sorry once again. Сергей, здравствуйте. У меня лекция сейчас идет у иностранных студентов, Сергей. Лекцию читаю сейчас в прямом эфире. Да-да-да. Чуть-чуть позже перезвоню. Вот. Двойная бифуркационная, двойной линейный шунт. Both line bypass, да? Итак, it will be classic operation. It will be classic type of treatment, chest patient. Conservative treatment and conservative treatment. Reduc, Tabata.
Yes, sir. Maybe
choice only 3 main steps of conservative treatment. Choice only 3 main steps, please.
Maybe bed rest. No.
No, it's not conservative treatment. It's on the recommendation of doctors.
Maybe some medications like antiplatelets.
Antiplatelet drugs for the reduce of any complication, myocardial infarction, as example. The patient with obliterative atherosclerosis may have multifocal destroy of artery, да? As example, destroy of cardiac artery, destroy of carotid artery. You can check after putting of diagnosis, placement of the diagnosis, not putting, I think. The diagnosis, you can check problem with heart, да? As example. So, так, first spasmolytic drugs, secondary spasmolytic drugs, first anti-aggregants, да? You can suggest for the patient cilostazol as reduce of intermittent claudication. What? It will be 3 main group of drugs for the patient with atherosclerosis. Ну вот, и теперь, хорошо, спасибо. Давайте далее. И это стенд. Ну и ничего подобного. Почему? Еще раз. Ну, давайте еще раз вот так. Can you see animation? 3D animation, да, of stand?
Not yet, sir.
Now? Why? And now?
Yes.
Okay. Stand. Function of the contralateral common femoral artery. Function on the contralateral common femoral artery. We can have problem on the left, and here function right common femoral artery. Introduce of guide wider with soft end. You may see here placement of catheter during chest introducer. We can We can placement catheter. Here we can make balloon plastic, intravascular balloon plastic, pre-dilation. Next step, pre-dilation of the artery. After that, placement stents. Use of opening stents with drugs into superficial. And after that, post-dilation of stents. For the correct position of the stents. You can know that life of the stents not so long. It may be 5 years. It may be even less. But after 5 years of placement stenting, the patient may have more big collateral mesh around cheese point with occlusion or stenosis. Stenosis divided on the two parts. Stenosis divided on the two parts is clinical main stenosis. Clinical main stenosis. Давайте вот так красный возьмем. Clinical main stenosis. It means 50-70%, да? It's lumen. It's maybe so 50, like here. 50, 70 stenosis. 50 and more, it's clinical main stenosis. We may suggest for the patient endovascular method of treatment. And more than 80% stenosis, we can calculate as critical stenosis. More than 80% stenosis, calculate as critical stenosis, like here. What is lumen of the artery, and problem with blood supply here. And 100% will be occlusion. All stenosis with more than 50%, 51 included and more, needed on the surgical treatment, endovascular or classic methods of treatment. Aortobifemoral bypass surgery. Aortobifemoral bypass surgery. Can you listen? Can you hear?
A vertical incision
Yes.
is employed to open the abdomen.
Yes.
Aortobifemoral bypass
Once the
surgery.
layers of the abdominal wall and the anterior peritoneum are open, a series of retractors are used to move the intestines and expose the posterior layer of the peritoneum. Posterior peritoneum is then opened to expose the aorta. And here again we see the area of the distal aorta completely obstructed by atherosclerotic plaque. Here are the iliac arteries which lie between the aorta and the femoral arteries. A vascular clamp is applied across the aorta above the level of obstruction. The diseased section of the aorta is then removed. The distal portion of the aorta is then tied off. The synthetic Dacron graft is then stitched or sutured to the upper or proximal portion of the aorta. While this particular technique I'm discussing today utilizes a synthetic graft, grafting may also be accomplished using veins which are harvested from the patient at the beginning of the procedure. The choice of a synthetic versus a venous graft is partly up to the personal preference of a surgeon, but may also be dictated by the presence or absence of good quality veins in a particular patient. Also, in a situation where a bilateral bypass is required, A synthetic graft, such as the one pictured here, requires only 3 points of attachment, whereas patient veins would require 4 separate points of attachment, 2 points of attachment for each vein on either side of the aorta. Now that the upper portion or proximal portion of the graft has been attached, preparations must be made to attach the limbs. Using 2 fingers of the hand, the surgeon gently separates the tissues in the retroperitoneal space. This is known as blunt dissection and avoids the use of instruments which may puncture or tear vital structures. This technique creates a retroperitoneal tunnel through which one limb of the Dacron graft will be pulled. A clamp known as a peon clamp is used to pull the limb of the graft through the retroperitoneal tunnel. Particularly blunt tip, which reduces the chance of injury to vital structures as it first grasps and then pulls the graft limb through the retroperitoneal tunnel. Now applied across both limbs of the Dacron graft. The aortic clamp is removed. Blood now flows into the limbs under systemic arterial pressure. This serves 2 purposes. Previously attached portion of the Dacron graft is tested for leaks, and twisting or kinking of the limbs of the Dacron graft is prevented throughout the rest of the procedure. It is inserted until the tip can be seen in the previously made peritoneal incision. Here is a close-up view showing the relationship between the cecum of the large intestine, the iliac artery, and the tip of the peon clamp as it moves safely through the previously created retroperitoneal tunnel. Is used to bring the end of the limb towards the peon clamp, and the vascular clamp removed. Limb through the retroperitoneal tunnel and into the groin incision. The left graft limb is pulled down into the area of the left femoral artery by the same technique. Once both graft limbs have been sutured to their respective femoral arteries, the bypass procedure is complete.
So it was aorta B femoral bypass with using of spatial synthetic graft as Dacron, as example. The polytetrafluoroethylene PTFE synthetic graft is the modern material. For the line grafts, to small artery, as example femoral tibial bypass, doctors may use autograft as autograft. As autograft may use Gritis Safinavin without varicose dilation, without disease, chronic vein disease. We may use even small vessels for the line bypass surgery if the patient needed on the small diameter of the of graft. So it was classic bypass surgery of treatment the patient with obliterative atherosclerosis, So I'm finished. If you not have the questions, see you soon on the next time, on the next lecture. Goodbye.
Thank you, doctor.
До свидания, sir.
Goodbye.
До свидания.
До свидания, sir.